Hi, everybody. Happy Diwali and Salam Mubarak to all those who celebrate. Welcome to today's Center for Healthcare Strategies webinar, Pursuing Health Equity Goals Despite Adverse Environments, Perspectives from the Field, made possible through support from Genentech. My name is Shilpa Patel. I'm the Associate Director for Health Equity at the Center for Healthcare Strategies, or CHCS as we like to call it. And I'm very excited to welcome you here today for what I'm sure is going to be a very insightful and honest conversation. I just wanted to remind you at the end of today's session, a brief online evaluation will pop up on your screen where feedback is really important to us at CHCS, and we hope that you take a moment to complete the survey. Next slide, please. Over the next hour or so, we'll share some key strategies to advance health equity goals in adverse or challenging environments, and then we'll have a panel discussion with some health equity champions about how they've navigated difficult situations. We'll then have a moderated Q&A before wrapping up the webinar. Next slide. Before we get started, I just want to go over a couple of logistics. To eliminate background noise, audio lines are muted during today's event. If you want to ask a question to our awesome panelists, we ask that you use the Q&A icon located at the bottom of the screen. And to engage with us throughout the conversation, please feel free to use the reactions and share your emojis about various comments or thoughts shared by panelists. And lastly, we are recording the session today, but due to the potential sensitivities of the topic, we will decide after the webinar if we will send the recording out to registrants, and we appreciate your patience and understanding with this decision. Next slide. In terms of today's speakers and panelists, I'm joined by my colleagues at CHCS, Abina and Jahira, and a wonderful lineup of panelists. Dr. Anisha Gandhi is the Director of Racial Equity and Social Justice Initiatives for the New York City Department of Health and Mental Hygiene's Bureau of Hepatitis, HIV, and Sexually Transmitted Infections. In her role, she leads efforts to embed a racial equity lens across programmatic, capacity building, research, and evaluation activities, and to advance workforce equity. Dr. Dana E. Crawford is the mother of 2 young children and a clinical psychologist. Dr. Crawford is also a scholar in residence at Columbia University's Zuckerman Institute, and she's also the developer of the Crawford Bias Reduction Theory and Training, and serves as a cultural bias consultant with organizations across the United States. Dana Flannery is a public health policy expert and leader who drives innovation within Medicaid programs. Dana recently served at the Arizona Healthcare Cost Containment System in 2 senior level capacities, Senior Policy Advisor to the Director and the Assistant Director of the Division of Community Advocacy and Intergovernmental Relations. Kevin Wick grew up on his family's dairy farm in Leavenworth, Kansas. He and his 2 brothers all were diagnosed at a very young age with sickle cell disease. Kevin graduated from the University of Kansas and worked in pharmaceutical sales and management for 23 years before taking an early retirement due to complications from his sickle cell disease. Since retirement, he has earned his master's degree from Walden University and a community health worker certification. Kevin currently volunteers as president of the Uriel E. Owen Sickle Cell Disease Association of the Midwest and is chairman of the Patient and Family Advocacy Council at University Health, both in Kansas City. Thank you to all of our panelists for joining us. We also want to thank and acknowledge our advisory committee members, interviewees, small group convening participants, and CHCSers, past and current colleagues who initiated and really moved this work forward, and previous partners in the original Genentech project for their contribution throughout this entire project. Next slide. Before we get started on this awesome conversation, I just wanted to give a little bit of background on the Center for Healthcare Strategies, or CHCS. We are a nonprofit organization policy implementation partner based in New Jersey, but working across the United States and territories that works with state and federal agencies, health plans, providers, community-based organizations, and community members nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid. I'll now pass this over to my colleague, Abina, to get us started.
Thank you, Shilpa. With funding from Genentech, the Center for Healthcare Strategies initiated a project titled Co-Creating Solutions to Address Racism and Disparities in Oncology. CHCS facilitated a learning collaborative with 3 community and healthcare partnerships to enhance healthcare systems and community partnerships focused on identifying, co-developing, and testing solutions that address racial and ethnic disparities in oncology care and outcomes. And 2, to highlight mechanisms for healthcare systems to address institutional bias and racism inherent in cancer care for communities of color, and to establish measures to track progress. During this learning collaborative, one of the partners was experiencing challenges with talking about health equity due to state policy restrictions. Despite this adverse environment, the partner continued to work towards advancing health equity goals and had to be strategic, nimble, thoughtful, and agile about how she discussed this work. This dynamic experienced by our partner and many across the nation led to this exploratory project. CHCS, along with an amazing advisory committee and our wonderful consultant, Dr. Dana E. Crawford, embarked on a journey to better understand how health equity champions can maintain momentum to advance health equity in adverse environments. We had 2 goals. The first one was to better understand the impact of working within regulated environments that limit engaging in health equity work. And the second goal was to explore how individuals and organizations strategize and advance health equity goals despite cultural and environmental barriers within their organizations and externally. So to do this, we conducted a literature review, interviewed 12 individuals from the community-based organizations, healthcare systems, and state and local governments, and hosted a small group convening to help us better understand their experiences in working in restrictive environments and how they continue to work towards their health equity goals. So on the next few slides, I'll share highlights about the 5 key strategies that we uncovered during the project, along with an example for each strategy. So the first strategy is to build and develop internal organizational structures and processes. Supportive internal structures can help leaders create coherence between external and internal environments, ensure that colleagues are working toward a shared mission, and create a workplace where staff and leadership are involved in decision-making. Creating this kind of structure and process provides regular opportunities to learn, create, strategize, and collaborate. A couple ways to facilitate this process are to create action-oriented work groups to drive change and to obtain external support and resources for organizational development. One example of how an internal work group can drive equity is in Virginia. Under Governor Ralph Northam's administration, Virginia Medicaid's senior leadership team developed an internal committee to focus on workplace diversity, equity, and inclusion initiatives. One of the tasks of the group was to administer an engagement survey to better understand the experiences of employees. Employees indicated that there were inequities in some staff salaries compared to their peers in the survey responses. To further investigate this, the leadership team conducted a review of staff salaries. Findings revealed that salaries were lower for women, particularly women of color, compared to other staff. The data from this effort helped build the case for equitable changes within the agency, and salaries were adjusted to eliminate disparities in pay. On the next slide, we'll discuss the next strategy, which is to tailor messaging and communications for your target audience. Through our interviews, we learned that when health equity champions understand what motivates their audience, they can think strategically about tailored messaging, both internal and external, accordingly. By using language that resonates with your audience's shared values and using data-informed and evidence-based solutions to strengthen messaging, this can help organizations and state agencies to move the needle on health equity work. For example, Race Forward is a national racial justice organization that uses a targeted universalism strategy that can be effective in many environments. Targeted universalism emphasizes that addressing inequities for a specific population has the potential to improve outcomes for all. This type of messaging can be helpful, for example, in the maternal health and food insecurity spaces where health disparities exist for specific groups. Ideally, policy changes targeting birthing people and those experiencing food insecurity would improve outcomes for all people, and particularly for those who are experiencing bias and injustices. On the next slide, we'll discuss the third strategy, which is to engage in community-driven interventions. We know that community members bring so much lived experience to this work, and it's critical for state agencies and organizations to engage and center the voices of those who experience services and policy design and implementation. In addition, community members should be supported and fairly compensated for their time and expertise. For example, in Alabama, state public health officials knew that Spanish-speaking undocumented immigrants and their families were hesitant to connect with state government agencies due to the fear of immigration policy enforcement. During the worst months of the COVID-19 pandemic, volunteers and state public health staff collaborated with Spanish-speaking doctors and grassroots organizations to provide support to the community. They knocked on doors to better understand the community's concerns about the COVID-19 vaccines, provided information to help individuals make informed decisions, and shared safe and comfortable vaccination locations. Because of these proactive efforts to partner with trusted voices in the community, the state had high vaccination rates among the Spanish-speaking population, which was a direct result of the intentionality of their outreach efforts. On the next slide, we'll discuss the next strategy, which is to commit to progress and humility. This work can be extremely difficult in any environment, but can especially be very taxing when leading these efforts in adverse environments. Just because you're not moving as fast as another state or community does not mean you're not making progress. One of our amazing advisory committee members said it best, incremental is monumental. Health equity champions should determine the right pace and approach based on their audience's needs, promote progress at the individual level, and be transparent about any mistakes they may make along the way, because inevitably mistakes will be made. When internal equity work is challenging, aligning projects with funding and other opportunities and linking health equity work with quality and accreditation may be helpful and get some traction from leadership. For example, many state Medicaid agencies are using policy levers to address inequities. To improve health outcomes for all birthing individuals, and particularly birthing people of color, Medicaid state agencies have pursued eligibility coverage, such as 12 months postpartum coverage, and benefit expansions like covering doula services. The Federal Centers for Medicare and Medicaid Services have prioritized health equity and is incorporating equity requirements in both payments and healthcare system transformation models as well. Lastly, on our next slide, the strategy here that we'll be talking about is prioritizing purpose, professional development, and self and collective care. Health equity leaders frequently experience burnout, moral injury, and pessimism. Being grounded in one's purpose, professional development, and both self and collective care can play a critical role when pursuing health equity. One of the ways organizations can promote this is to redesign organizational policies to advance professional and leadership development. Some organizations provide one-on-one leadership coaching, access to professional development opportunities for staff, and prioritize time to practice self and collective care. Collective care creates a space for health equity champions to be open and vulnerable about their experiences and can help them to learn and unlearn, heal, and build a network of support. Building these connection points are extremely important for health equity champions. However, when a role is no longer fulfilling personal and professional goals and is feeling toxic and unsafe, it's okay to step away. One of our awesome advisory committee members said it best, it's not a sprint, it's not a marathon, it's a relay race. You've ran as fast as you can, and now it's time to pass the baton to someone else. Sometimes a new role or a new environment can be the catalyst to the next great professional adventure. I know I went through these strategies pretty quickly, so we encourage you to read the recently published brief on our website, Maintaining Momentum to Advance Health Equity in Adverse Environments, which provides more examples of these strategies. I'm now excited to transition to our panelist discussion. As Shilpa said, we have a wonderful group of health equity champions who will offer research, community member, and state and local government perspectives. Panelists, thank you all so much for joining us today. Thank you all. It's great to see your faces. So to get us started, I thought it would be best for us to kind of lean into the last strategy about prioritizing self and collective care. I know how hard you all work in your day-to-day to advance health equity goals in your communities. Can each of you describe one way in which you have practiced self or collective care, especially working in the environments that you work in? Anyone can jump in if they'd like to go first, and then I'd love to hear from each of you.
Well, I'll start us off. Greetings, salutations, well wishes, everyone. Thank you for making the time to do something that is very important, and that's having this conversation. There is this meme that goes around, and at the top it says, practice self-care. My therapist says practice self-care. And then it shows a picture of the therapist who is dried up and shriveled. And often I find that, just quite honestly, that I am better at recognizing the need for self-care than actually always engaging in it. But what have been the guiding principles for me is differentiating between self-care and self-soothing. So self-soothing are the things that you do to help you feel better. It may be binge watching a show. It may be taking a lot of naps. It may be checking out. Those are self-soothing behaviors. They help you feel better. Self-care are the behaviors that you engage in to continue to grow and sustain the work that you're doing. And it may be times that your self-care might not even feel good. So for example, waking up at 5 o'clock in the morning and working out may not feel good, but that's going to help me. It feels good later. That's going to help me maintain what I need to do in the world. And so for me, having a harmony between those two, not always a balance, but a harmony between self-soothing and self-care and knowing when to do which is critical. The other part is having a community that is willing to call you in to say, hey, I think you're fried. I think you're burnt out. I notice that you're having more irritability than I typically see. And so for me, that process isn't just an individual, it's collective. It's noticing it in my community. And the last thing that I do is actually have a group of people who believe in this work. So in those moments where I feel burnt out, where the load feels too heavy, there's someone to say, hey, you know what, I can carry your bag for you for this next mile. And so I think those key components, self-soothing, self-care, community, calling out, and routine are really critical strategies.
Thanks for that, Dana. Really appreciate that distinction between care and soothing. Happy to take it on next. I think, and this also has, I think, gotten more attention over the last few years, partly because of some really great writers and thinkers who have put it out there, like Adrienne Maree Brown. But a reminder, that that doing this really this work that can be both emotionally and cognitively taxing and require a lot of that labor does not always need to be heavy. That there can and should be joy in it and levity in it, and so it's really nice to, that's part of the reason that investing in relationships and the people you do equity work with matters, because then you can also have fun and laughter be part of the work itself. So I think for me, that's part of it, is feeling like I can do the work, showing up as my full self, which is also a person that enjoys being able to be light and be, a little bit silly sometimes, even while we take on these really hard topics. And it's not to be dismissive about how important they are, but just recognizing that we are full people that need to also have joy in these many hours of hard work. So I'll stop there.
That was very well put. I think that doing this work, we have a wonderful opportunity to lead individuals through this work and to also be led. And going back to what Abina mentioned about coaching, I think that is very critical in the process and making, whether you're being coached or you're coaching, that very safe space to have super difficult conversations, candid conversations, and really recognize how you're feeling, allowing that safe space to debrief on what came up for you throughout the work, maybe through a stakeholder engagement, maybe things that were said that really hurt you as you were trying to better these efforts. And then, kind of having that tagline of what you're going to come back to as you navigate this work. So whether it's self-care and self-soothing, when you're in the moment and in the heat of the work, what can you come back to? And what I always come back to is stay curious. So no matter what is going on throughout the dialogue, no matter what feelings and expressions of opinions are being made, really recognizing we all have lived experiences and we all come from different walks of life. And what can I learn from these individuals? What can I gain from this experience outside of the fact that it can be stressful and difficult, but really just staying curious in the process.
So I will just add as well, everybody has great examples of how they do self-care. And, as me as a patient, I do a lot of mindfulness and just really try to internalize, my struggles and let those go. I also have really learned over the years, I'm really responsible for setting boundaries and making sure that I don't overcommit in my processes. And part of that is just really creating great networks and really relying on others to help me through this work. I've learned very quickly, I can't do this alone. It takes a village to make some changes. And we definitely celebrate the wins that we do have, but we don't wallow in our losses. My advisor at University Health has really been great in really talking about, we can't change everything. Our responsibility is to put the ripples in the water. And so I really kind of rely on that message all the time that, everything we do is not going to be a win every single time, but we are making change and it's a process.
Thank you so much. Those are awesome responses. I love the difference between the self-soothing and the self-care and the fact that they're both important, really finding joy in this work. Another group that I work with CHCS, one of the members said, joy and justice, there's joy in this work. So really having folks that we connect with that bring that joy in this work is so important. Investing in coaching, being led and leading and staying curious and connected with the community is so important. And the mindfulness piece, Kevin, thank you so much for raising that. And we're responsible for setting those boundaries, not putting too much on our plate, relying on the village, I think is super important when thinking about self-care and collective care. So thank you all so much for just sharing those insights. And hopefully some of our audience members resonate with those responses or maybe have some, some ideas on how they can incorporate self and collective care in their work. Dr. Dana Crawford, I would like to start with you first. So in this brief, we discussed the importance of tailoring messaging for specific audiences. Can you touch on the need, particularly for those most affected by systemic and institutionalized marginalization, to name inequity in all of its forms, yet at times feel compelled to sort of code switch in order to make progress in this space? How do you do this effectively without feeling maybe like you're being inauthentic?
Yeah, thank you for that question. It's a really hard one, just hearing those words. I had read them before you asked, but hearing them, my heart started beating pretty quickly, even thinking about the ways in which we have to adjust to get our message across. This platform in itself, we spent a lot of time talking about how do we have this conversation. So, we have these beautiful words that describe this webinar, but the backstory is what we're really talking about is asking for equity, asking for inclusion, pushing for diversity, equity, inclusion, belonging in environments that are pushing against those priorities, that are pushing against those goals, and sometimes pushing in very subtle ways where maybe you're a consultant and someone just doesn't call you back. Maybe in very direct and explicit ways by saying these words are banned and we are not going to be reimbursing if you say these words like equity, if you say inclusion. And so even deciding to have a conversation about how do you keep moving forward in this work is in some ways putting us at risk for letting that same group of people who are against this movement of inclusion, we're kind of telling our trade secrets. So, how do you be effective? Well, I think first and foremost, for a lot of professionals, we have been code switching and it's been called professionalism. And we are often put in a box where we don't have a freedom to express our true selves. We feel like we have to adjust and just to name code switching, we have to adjust our language, our gestures, our references, our speech. We have to get the exact wording. Think about how long you've spent trying to get that email crafted perfectly so it doesn't have the wrong tone. All of those things are labors and they're exhausting and they require mental energy. So the first thing that I would say is understand when you are code switching and what price you are paying. It is not free. Once you understand why you're code switching, break the habit so it's not just what we do, but instead you're doing it very strategically and intentionally, and you're understanding who's calling for you to do that. Okay, so this group says that I have to, the way they respond, this group doesn't respond to my emails if I use these terms. Okay, this group gets really excited. So really slowing down and reflecting. What I have found so often in this work is we're so reactive. Understandably so. There is so many hideous things happening in the world, so much injustice, and we want to jump up. Justice can't wait. However, in that reactivity, we often miss opportunities for strategy. So I think those are some really critical elements. I could go on and on, but those are my big hitters.
Yeah, no, that's so helpful, Dr. Crawford. And I think really your point about understanding the groups or the folks that you have to code switch for, right, in terms of moving things forward is really important. And once you understand sort of the group, right, you can really think about your strategy and how you can do it thoughtfully. And I think that really kind of lends its way to thinking a little bit about like the community, right, which is so important in working with and centering their voices when doing this work. And Kevin, I'd like to bring you into the conversation. In the brief, we really discussed the importance of engaging in community-driven interventions. And as the chair of your patient family advisory committee in the health system, I'd love to hear from you, like what makes these types of groups really successful in advancing health equity initiatives?
Sure. I think there's several key characteristics that have really helped propel our organization and our PFAC to be successful. First and foremost, the organization has to adopt and embrace the correct culture to make these changes happen. So I'm very fortunate that our hospital has done just that. And when the PFAC was started in 2019, that culture and that motto of our PFAC was lived examples. And so that has helped propel our efforts within the hospital. The other thing is with our organization, we make sure that our PFAC has a very diverse membership, and it is including many, many people from the community as well as patients that are within the hospital itself. So that we capture as many different diverse interpretations of whatever it is that we're working on at the time. And then, I've always said that it's so important for PFACs to make sure that we have representation at the table. So we luckily have had PFAC membership involved with multiple committees throughout the hospital, not just our PFAC committee. And I was hesitant at first when I joined the PFAC, thinking, I've been on committees before where we're on a committee to be on a committee to check a box for the hospital. And that was not the case. We had advisors, we had the culture with the hospital to really embrace what we are doing. And that is like lived examples within our hospital that we are working and making some changes, and we've had some great momentum. And so those are true things that we definitely need. The other thing I would say is transparency and open communication is huge. Our hospital does a lot with making sure that PFAC members, we're community members. We don't always know the in and out of the hospital and the working. We have training at every meeting from different departments in the hospital so that we are aware of what constraints they have that they have to work through. And that helps guide us in our decision making. And so, for that two-way feedback, it's great for us. It's a learning example, but it also allows us to be more strategic in what we do in terms of making changes. So, there's several things, but those are the key things I think is key to make sure that a PFAC is successful.
I love that. Thank you so much, Kevin. And I think one of the first things you mentioned about like just really having the right culture within the organization is really key, right? Like not every organization might be ready at a certain time to start a PFAC, right? And doing that like internal work is extremely important before you really start bringing the community in. Because I think once you do that work, you're a little bit more successful in the transparency, right? The open communications piece, having these trainings, making sure that your PFAC has diverse membership from the system level and also with the community members. So thank you so much for just really raising that. And I think that makes me want to ask Dr. Anisha Gandhi a little bit about like kind of that like agency work, right? In terms of like, how do you really develop that kind of right culture within an agency? I think a lot of the fact that like sometimes if your title is like, Director of Health Equity, right? Like you understand this, but maybe not everybody within the organization really understands the value of this work and why it's so important. So Dr. Gandhi, do you mind maybe just like helping us to understand a little bit about how organizations and governmental agencies can really support staff through all levels of the organization, really feel connected to this mission of health equity work?
Sure. So I think, so to acknowledge, for those who are not aware, the New York City Health Department, where I am based, is one of the largest health departments in the nation, if not also the world. We have, somewhere between 6,500 and 7,500 staff based all over New York City and engage with stakeholders all over the city, healthcare providers, faith-based organizations, community-based organizations, community members themselves, as well as partnering with, state, national organizations and other jurisdictions where we also provide capacity building assistance. And often because we are, a progressive city and one that is unfortunately the nexus of a lot of syndemics and, certain chronic health issues, infectious diseases, et cetera, we end up with a high burden of disease and an opportunity to study those things in urban environments, and thus also an opportunity to really lead with innovation and kind of test things out and also support kind of progressive policies to address both health equity and public health at large. So we are lucky to have had strong leadership support to really do deep internal reform centering anti-racism and racial equity and social justice as an agency priority. And the thinking behind that framework was that if we change the way we work internally in all that we do, not just our public health programming, but also the way we do budgets and contracts, the way we actually train our staff and what our staff are required to be trained in, the way that we collect and disseminate data in all of these different domains, as well as how we treat our staff and support them, our workforce equity, that shifts the way that we then practice public health and ultimately will ideally lead to a substantial reduction in health inequities. But that, sounds all well and good, but can be pretty hard to connect to for somebody whose only job is to process everybody's paychecks. And so I think it does become critical to really connect it to people's day-to-day jobs about how we are also part of our constituency. So our job at the New York City Health Department is to protect and promote the health of all New Yorkers. We also, by definition and by rule, are also all New Yorkers. And many of our staff are people of color and come from more than one marginalized background. Many of our staff live in what we deem are high priority neighborhoods, or neighborhoods that have experienced historic underinvestment and underservice by our government agencies, including public health. Many people have experienced bias or discrimination within either their current or previous workplace, or discrimination within healthcare settings. So this is not a reality divorced from our own. So when we advance the mission of our health department, and especially that equity mission, we are bettering our own futures and opportunities, and saying that the standard for all of us, including me, needs to be higher. So I think that's part of it. And I think that what has also helped is that we are working to even more closely align our workforce equity and internal racial equity and social justice initiatives with our external work, because the public health piece is super critical, right? We are here to serve New York and New Yorkers. We, however, cannot do that when we are not cleaning up our own house, and when we are not taking equity seriously internally. And so I think that is another piece that we've collected internal staff data, and it is critical for us to report that back, that that this percentage of staff do experience bias within the workplace, that they feel like they have to work twice as hard or harder to be treated equally, or that they're being passed over for promotions, that there's pay inequity as demonstrated by analyses, or and also demonstrating the positives of people that feel like their cultural backgrounds are assets and values, that they feel like they have unique things to contribute. So really making sure that we are reporting that back and reflecting that back to staff, to say that it's not only the work that you're doing, but the way that you contribute to and help shape our internal culture makes a difference. And because those things, as Dr. Crawford mentioned, as that we all know, that when you are experiencing those either micro or macro aggressions throughout your workday, if you are feeling less than, or if you're kind of entitled to go through your day without worrying about how anybody else feels, those things affect your health. And one person is put on a track to have better opportunities to achieve full health and have their well-being intact, while another person is then taking on chronic stress and having to relieve that in different ways, and sort of do a lot more to stay healthy. And that in and of itself is an inequity that is, that we have a responsibility to correct. I hope that answered your question.
Absolutely, Dr. Gandhi. And I really want to just reiterate your point about really connecting staff with their own personal experiences, right, throughout all levels of the organization, right? For some people that kind of eat, sleep, breathe this work, right? Like, we get it, right? But for some folks who, like you said, are maybe crunching in numbers all day or helping with the budget, right? They might not realize that, but just taking a moment and doing that kind of internal work and encouraging folks to just reflect on their own health experiences, right? Any biases that they might have experienced, I think really helps connect them to the work, and also really helps them to be connected with community, right? And the importance of doing this health equity work. So I really appreciate you for mentioning that. Another piece that I think that you said that really, I think, leads us to our next question with Dana was around sort of working in New York, working in a state that has a little bit more progressive policies, right? And thankfully your city really invested in this health equity, anti-racist kind of internal work. But we do know that, and even in these kind of communities, it's still hard to do this work, right? Just because you have that leadership buy-in doesn't make it completely easy. But we know, obviously, too, that if you are dealing with some more intense restrictions, that can be a little bit harder to do these kind of things. So, Dana, I'd like to bring you into this conversation. Being a state official or a former state official, I think you definitely recognize the importance of sort of navigating the complex federal, local priorities and kind of political contexts. So I'd love to hear from you a little bit about what are some key challenges or policy limitations that you were faced with when working at the state level. And if you can just share maybe a strategy or two of how you kind of navigated these limitations.
Sure. So thanks so much for that question, Abina. I was honored to be able to put forth so many policy changes during my time in Arizona. And there was always that duality of having a federal conversation and a state conversation and being very mindful of that. And really finding solutions that could make everyone happy can be difficult, right? But that is what you're tasked with. And that's what you're honored to be able to do. And so I think sometimes in the equity conversations, things get really narrow really quickly. And it gets super specific, and people can become detached because maybe that doesn't apply to them, or maybe they don't see their, part of that. And so sometimes it's best to come back up and really rise to things that can bring people together. And so not only are there added benefits of equity efforts, which I'll get to in a second, but just that common ground. When you can find common ground and you can get everyone to have an equal investment or an investment, right, at the table, that's helpful. I think with equity, when you're looking at it, what would impact everyone at the table? What's an equity issue that people could start to contemplate that will likely hit everyone? Great example can be aging. We're all aging. We all have loved ones or parents or someone very important in our life that's facing aging. And what does that look like? There's just so many ways to bring connectivity to the conversation, and then also bring it back once you go really high to that local issue of you are a member of this community. How can we make this community thrive together, survive and thrive, right? And what can we do to have that conversation and be methodical about it, be strategic about it. Don't just say, we need a quick fix here, or like Dr. Crawford said, we need to be reactive. Let's keep reacting. Let's look at the data. Let's look at the story of our community. Let's be acknowledging of what is occurring and what is not occurring, and what can we do that is going to have the biggest impact. And then once you get to that impact, as you may lose people along the conversation or have some difficulties, there's also other benefits that come from this work, right? There's obviously the clear benefit of equity, but then there's improved health outcomes, healthier communities, lower healthcare costs, more productive workforce, community resilience. All of that comes along with this work as a byproduct. And so really helping people see that along the way and being mindful. So when you set out to do these amazing things through all of your policy levers, whether in Medicaid, for example, state plan or waiver, how are you going to measure the efficacy of this? How are you going to be honest and transparent with your communities about, did this work? Did we do what we wanted to do? Are we seeing those outcomes? Having that conversation and getting that input on the front end of how will you know, community, that we've done right by you, and really holding true to that and being effective in that. And then I think the last thing I would say on this is consistency. People start and stop these conversations all the time, and that breaks community trust. That reactivity, that, oh, this happened, so now we're going to do this. That hurts communities and that hurts that trust. And so really having that consistent conversation, whether it's an internal and an external, like Kevin said with the PFAC, all of these agencies are going to have advisory committees one way or the other. Use them, leverage them, use that wisdom, and be mindful and strategic about how you go about it.
Thank you so much for that, Dana. And I think really something that's just like sticking with me are like all the other like outcomes, right? And like positives that come from doing this work. You mentioned community resilience, right? More productivity, improved health outcomes, right? Like there's so many important byproducts that we can all truly like be invested in and be excited about, that can really help us drive this work. And your point about not really, like, of course it's important to raise like the inequities that are happening, but really making sure that sometimes you come up a little bit, which I think is really helpful for just like training and support and providing the context, and really helping to build buy-in, right? And getting to a common ground, because like your example is perfect, right? We can all be committed to really ensuring that we have an aging population that is served well, right? And taken well care of. Your last piece about community and how consistency is key is making me want to bring Kevin into the conversation, right? About really making sure that we're not breaking community trust. Kevin, I think one of the things that we sometimes recognize is that the relationships between systems and community members can sometimes feel extractive, right? It's like we need all this information from community, and then that's basically it, right? There's not that much transparency. There's not much of a bi-directional conversation. So I'd love to hear from you, Kevin, about like what are some strategies that healthcare professionals, systems, state, local agencies can really use to ensure that they're co-creating solutions together and that the relationship doesn't feel extractive in nature.
Sure. Looking at that, I really think that the first and foremost step that organizations need to make is making sure that they're involved in the community, they're present, and not just when they need something. They need to be present, and it needs to be consistently present and not just in and out. And making sure that there are processes that are created to really help provide insights and guidance and understanding of the community. And when those are implemented with committees that are, diverse, and they're speaking with people that look like them, they're going to get a better response from the community, and that's going to help break down that trust factor. Our hospital is a safety net hospital that it's so important that we have staff that is looking like the patients that we serve, and that we're there, and that we are meeting patients where they're at. And so, yeah, we do have the SDOH committee that we've been working on, but making sure that, we go the extra mile and not just identify those patients that are, testing positive for SDOH issues, but we're making sure that we come up with solutions. So one of the perfect examples that we did at our hospital was we worked with community. And so when patients were testing positive for food insecurity, we not only just referred them to community food banks out in the community, we partnered with community food banks to bring an on-site pantry. And so we have an on-site pantry at the hospital now that is serving over 400 patients every single week. And so that is a way for us to make that extra step and break down that trust. And we're meeting the patients where they are. It's not one additional step that they're going to have to take to go to that food pantry. They can do that right when they come in for treatment. So, it's those little things that I think is really important for agencies to do, is to partner with community, but come up with creative solutions to make sure that it's not a further burden for patients to access some of these solutions that we're coming up with. And I think, the more that we do that as organizations, we're naturally going to break down that trust barrier with patients. But it's something that's not going to change overnight. This is something that we have to work on consistently. There's been so much that's happened over generations that we have to overcome. So it's a constant and commitment that we have to make as organizations, and partner with the community and make sure the community is involved with the organization. And that, again, it goes back to the open and honest communication. We have to be honest with these individuals if we're going to break down that trust factor. So there's several things that you can do as an organization to make sure that we are working with the patients in the community to address that trust factor.
And I'd love to just jump in. I love everything you shared, Kevin, and couldn't agree more. Just from speaking from the government institution side, the more that can be hardwired in as sort of a requirement from the government side, that it is the agency's responsibility to not only have something that is, community informed, but community driven, community partnered, that there is as much participation and engagement that a project really warrants and that is feasible. And I've shared a resource in the chat. Thank you so much for all the CHCS folks that are helping on the tech back end. But to, we have the examples like Ryan White funding, where there is always a jurisdictional planning council that is responsible for, that has consumers and people living with HIV and are otherwise HIV affected, voting on how that funding, federal funding, is allocated. That we have also worked on, although it gets a little bit tricky bureaucratically and administratively, of having community members participate in reviewing funding proposals and deciding who is awarded our government contracts doing HIV prevention work. And they receive the same training as our staff, so they can be mindful and conscientious reviewers. And I love, Kevin, that you described the ways that your advisory group has received all this education about the different ways that the healthcare setting works, so that they can be more empowered advocates. And then I would say too that, when there are public health emergencies, relying on, bringing in advisory bodies to absolutely weigh in on messaging. That's a place where it's like, there should be no code switching. We should be speaking in language that community members will understand, where the message is absolutely going to be clear in as many ways as different people and constituents need to hear it, right? Languages, slang, like what youth, like who needs to hear what, right? Like COVID affected everybody, and we need to get a message out there in terms of how to keep people safe that is going to resonate with people and is not some super technical speak that is just approved by the highest levels of leadership within a government institution. So as much as those things can become the rules for how government institutions work, that you cannot move forward without engaging a diverse set of community stakeholders that are truly representative of the population that is affected or that you're trying to reach, I would say is part of the way that we do need to move forward. And agreed, there's so much work left to be done, but I think moving toward true partnership is really necessary.
Yeah, I think this conversation about partnership, honesty, transparency is such a critical one. And I often find myself struggling because in these spaces, it ultimately goes to a conversation of like, how do we build trust with the community? That's always the question. And I wonder if the community actually should be trusting, have we earned trust? And I would love to explore a space of how do we demonstrate trustworthiness to communities? So often we're asking the community to give us information, so how we can give them information. We're going out in the community. But many times for decades, the government has failed them. These processes of going out, often we go out, we get the resource, we then tell them this is what we want. This is what we want you to do. I think about COVID, and it was not a lot of listening. It was a lot of why you're wrong, community. What your perspective of this disease is wrong. So how can I create information to get you to think the way that we want you to think as a government? And I think true authenticity and trustworthiness has a lot more listening. And I don't think, as institutions, as agencies, as groups, as coworkers, I don't think we're as good at listening as we could be. I think there needs to be a lot more spaces where we're talking about why people are against this, right? This whole conversation is about, how do you do DEI work? How do you do DEIB work in adverse environments? And I'm not sure how many of us have asked the question of, well, why are there adverse environments? What created this? And a lot of this was created in being reactive. If you just look up, why do people not like DEIB work? The reasons they don't like it is it doesn't feel like it's relevant. To Dr. Gandhi's point, it has to link directly to them. People don't feel like it's often a one-on-one, it's a one-size-fits-all approach, right? It doesn't feel personalized to that community, to that institution, to that organization. Often there's an emphasis on guilt and shame and how you're doing it wrong. A lot of the COVID messaging and other disease messaging is in a space of shaming. I think a lot of people are against this work because it doesn't bring the change that they're seeking. When we talk about measurement, because of that reactive approach, we're often funding and doing before we even know what success looks like. How will we know this program will be successful? And these are the critical questions of trustworthiness. So what I invite is for community members, when they have a group or organization coming to them, ask, what should I be looking for to know that they're trustworthy? They're asking for my feedback. Okay, how am I going to get the information that you use back to my community? So I'm going to give feedback on the grant. Am I going to hear about the grant? How many times have we asked for feedback on a grant and then we don't even inform the community that the grant happened, right? And so that circle of communication does not happen. We go out to the community, but we don't bring community in. The spaces that we create feel inaccessible. We may use accessible language, but when they walk in, they feel intimidated. And so all of these critical pieces are trustworthiness rather than trust. And I think that's really critical.
I would love to chime in just a second here. I completely, wholeheartedly agree with everything that you just said, Dr. Crawford. And then I think one step further would be the other end of that spectrum. And when we do go out to the community and we ask those very difficult questions and we get all of that input, I think something that many people miss the opportunity on is, what do you do with that? And what did their time, their energy, their sharing, their personal stories, everything, what did that result in? That's the piece that often also gets missed, is that we ask individuals for their time and we ask them to be vulnerable and we ask them for all of this stuff. And I do believe often it is with good intention. We want to do things in an informed way. That being said, if I don't come back to you and say, you helped develop this policy, which resulted in these health outcomes and improved lives, here are some member quotes for you for how people were impacted by the policy that you were able to be a part of. And whether it's through stakeholder groups or focus groups or any kind of work that we're doing, when we're exchanging individuals' time, which is very hard to come by, for policy development, we need to let them know what they developed, because they developed it too.
I love that. Thank you all so much for just this piece really on the trust building aspect and how important it is, right? And what does it really look like to create authentic partnership with community? So just really appreciate all of your insights there. We are about to transition to Q&A. So if folks want to start asking questions, although we already have a lot, so thank you so much. Please feel free to drop your question in the Q&A chat. But just really want to talk quickly about the piece around having conversations about diversity, equity, and inclusion, especially in communities where that is really difficult. We know the value of having conversations about diversity, equity, and inclusion internally, and how that leads to doing better work externally and advancing health equity. So would love for anyone to jump in here. We'll have time for one response, but we'd just love to hear from any one of you about, how do you respond to folks who feel like having these conversations about diversity, equity, and inclusion can inadvertently lead to new forms of discrimination or bias, right? And as we're having these explicit conversations, people feel uncomfortable, right? Because they feel like, well, now we're focusing on one group, and maybe they might feel a little bit targeted or ashamed or just not know how to engage in the conversation. So if I could just have one of you speak a little bit to this thought of the fact that having these conversations lead to new forms of discrimination, maybe how we can respond to these fears, right? So that people can truly engage in this dialogue.
So I'll quickly note that we have had tensions around otherness and race for as long as more than one, ethnic group of people has been on this land. And we have had oppression and injustice for as long as people have been on this land. And so we are not going to solve this overnight. We're also not going to solve these issues without some discomfort and uncomfortable conversations and unveiling of uncomfortable truths. So that also means that we also need to recognize a lot of people, especially people who are more marginalized because of their identities, have been uncomfortable for a very long time. So think of it more as a redistribution of that discomfort. And we are also just facing some data and some realities in health that I feel like nobody should be looking away from. The average life expectancy of a Black trans woman in this country is 35. That to me is unacceptable. And regardless, I am not a Black trans woman, but I cannot be a public health practitioner and be okay with that reality alongside my own. So that is something that having a foundational understanding for people to acknowledge that racism is not the exceptional experience, but rather the norm for most people of color in this country in some way. They are disadvantaged and will not have that full opportunity to reach full health, to reach their full potential, and that we are all both complicit in that and all have opportunities to work toward a better future that does not look like that, is really critical. So I think acknowledging those differences, our different realities and experiences, is we have to go through. We cannot go around.
I really appreciate that point, and just, yes, thank you for just voicing and naming. I think a really critical piece is recognizing how we got here. Like you said, this has been here since the beginning of time. But when we think about specifically to the question of DEI being banned, outlawed, you're not allowed to have these conversations, I think it's really critical that we recognize that even though people are going to be uncomfortable, many people are not skilled at being uncomfortable. That we live in a comfort culture, that people are striving to feel better in every single aspect of their existence. So I think the critical piece is teaching people the skill of being uncomfortable. So many times in this work, we say, well, people have to get comfortable. No, you just have to get comfortable with being uncomfortable. The second part is be willing to have a hard conversation. If someone, and it says specifically white people in the question, if someone is specifically saying we can't use these terms, I invite you to go sit down with them and understand what would make this person bring this much energy to a professional space that they are literally going into the point of banning something. I don't know about you all, but we are all time impoverished and we do not have enough time in our workday. So something must have happened that made you do that as your day and what you're going to put your energy for. And I don't think we're all often talking enough across the table about what happened, what occurred to make you say, you know what, you shouldn't say these words. That sounds really critical to me. And I don't think we listen to each other enough. It goes back to that same point.
Thank you. Thank you. Thank you so much, Dr. Gandhi, Dr. Crawford. Those insights are so helpful, right? And I think we just really have to, beautifully said, be comfortable with the discomfort of having these conversations, because for a long time, many of us have lived in that discomfort when talking about all the different injustices that we have faced as marginalized communities. So thank you both so much for your responses. So now we are going to transition to Q&A. So audience members, appreciate the questions that are coming in. We might not have time to go through all, but we will definitely try our best to go through some. So one person asked, how do we facilitate collective care with a small staff and with a larger staff? And we'd just love to hear some perspectives from you all about how you've been able to create that kind of collective care space in small teams and big teams as well.
So I'll kick this off, having in the last couple of years been in charge of both 300 people and also one person at various times. I really like to both model and encourage among other folks in our leadership team to really be embodying a humans first staff or employees or workers second approach. We are all so much more than the work we do in our given work days. People live in many directions and have many other responsibilities and many other richnesses to their life, and also many other challenges. So when there are outside traumas, when there are personal challenges, or really, big things to celebrate that are taking up a lot of people's attention and bandwidth, that is not a time to hammer down and be like, why aren't you getting more done? Acknowledge that people are human, give people flexibility around that, make space for that. And I think partly like that, you can do studies around whether that, results in, longer retention and loyalty, but at the very least, like that is better for the well-being of people in this like very challenging time that we are in. I mean, I don't think that we sufficiently acknowledge that we went through collective trauma during COVID there. And on top of that, so much racialized violence, so many conflicts globally. And I think people are in various stages of healing. Many people have not gotten a chance to heal because the hardship has not ended. And so letting people be human, and maybe that also means holding spaces at work for people to just come together and share, having a moment of silence to honor people who have been either lost or just who are having a hard time. Let people be emotional. For larger teams or even a team of 15, maybe consider having identity-based affinity groups so that people can share in safer spaces what their more unique experience and more kind of unique or specific challenges are like either inside or the workplace or beyond.
I'd love everything that you said. And I'd just like to add to that. I think it is such a wonderful honor that we have if we are in the capacity to lead a team, lead an agency, lead anyone, even our tiny humans we may be leading at home. And so really thinking forward as the fact that we all are human and we bring our human selves and our lived experience to every single thing that we do. And I think in leadership, especially in coaching or in mentorship, that human element can get lost. And it's about being reactive, doing the day's work, making sure that we're being very effective with our time. But, if we're not doing the self-soothing and the self-care and just honoring what's going on in our lives, we're missing something. And so I think as a leader, you have the ability to hold space for both. You can lead them through all of the work that they're going to do, and that's wonderful. But you can also lead them through their lives. You get to have a huge impact on their life if you allow it and if they allow it, right? And so creating that safe space. And then, again, going back to staying curious during those dialogues, but also always assuming the best of people, assuming those good intentions. And then when we're talking about teams, I think the chat had said something about like a 15-person team. I think, I don't like the term ground rules, but whatever terminology that you have for setting the stage for some of your more difficult conversations or vulnerable conversations is critical. Those shared agreements that you can develop amongst a team to honor each other, to honor the shared space, to honor that vulnerability is critical. Start with them, end with them. Make sure that you hold true to them. And then there are some conversations in your 15-person team, your 40-person team, your 1,000-person team that are going to need to be one-on-one. And you're going to need to debrief with someone later. And you're going to need that safety of, hey, if anything gets too much today, this is your exit opportunity. Here's how I will follow up with you. Here's my promise to you as a human that this may be difficult today. And then I think the other part of leadership, kind of going out of just looking at someone as a human, is preparedness. I think we brought up so many times today how difficult these conversations are. And from each of our own unique lens, every seat around the table, we have our own worries about how the conversation is going to go, how we're going to be perceived. Will people understand my good intentions? And we may fumble and we may not know what to say. And we may think all night long about what we said of, was it perfect? Did it get across my intent? Your staff are all having that same experience on a different level. And so preparedness and having some of those conversations, practicing those conversations for when they go out to stakeholders so they can increase their comfort level of these very difficult conversations and feel confident that it's coming from a good place, it's coming from good intentions, and they do valuable work and they are critical in where we move this forward.
Yeah, so I'm going to just add one thing to that. The question of collective healing or collective self-care, it implies, and to your point, Dana, that everyone wants a collective experience. Organizations have history, and sometimes these organizations have been historically harmful and have been toxic. And so now new leadership or leadership that just went to a retreat, or maybe leadership who's listening well on this webinar, decides that they want to create a space of collective healing. And some people are not going for it. Some people don't want to do collective healing. Someone told me, they have a team and they were like, let's do a retreat and we're going to all go in the woods. And they were the only people of color on the team. And they said nothing about going into the woods as the only person of color feels like healing for me. So I think it's really crucial that in our collective healing efforts, which are very beneficial, we also honor that healing has many, many different forms. I did see your comment about code switching. So earlier I used this language, code switching. Harvard Business Review defines code switching as adjusting your language, your speech, your gestures, your references in hopes of getting fair treatment, acceptance, employment. And so when I think about examples of code switching, it looks like, how do you show up in the workplace? Specifically, as a woman, how do I wear my clothing? What jewelry do I wear? How bright is my lipstick? How do I wear my hair? Should I wear it back? Should I not? If I wear glasses, does that make me look smart? If I don't wear glasses, does that make me seem more approachable? All of these subtle ways. I think about my LGBTQIA+ brothers, sisters, and non-binary siblings, the ways in which how they might carry themselves might reveal their identities, the ways that we are not able to bring our full selves to work, and we have to have a dual consciousness where we're thinking about, okay, how am I going to be perceived and received? And how do I communicate my actual job? And so wearing both of those lenses is exhausting, and it actually is a cognitive overload and will limit your ability to fully do your job because you're worried about how you're perceived while you're doing that job. So hopefully that answers that question.
Thank you so much. Well said. Thank you for giving us that kind of definition, what examples of code switching look like, because I think sometimes we think of it like in the verbal sense, like how are we saying something differently, right? But just our appearance, how we show up in the workplace, can all be different examples of code switching. So I think I might have time for one question. And Kevin, I wanted to pose this one to you because someone wanted to talk a little bit about community engagement and technological advancements. So with the emergence of new technologies, would love it, Kevin, if you can maybe share a comment on what community presence and engagement could look like for virtual health, telehealth, anyone that's kind of working more in the health technology space to ensure patient-centeredness.
Yeah, I'll take a stab at that. For our organization, we have really tried to reach out to the community with various like social media and other technology platforms to make sure that we are trying to reach them the best way possible and meet them where they're at as well. So we are working on trying to do apps that we can download for food finding, finding where the food banks are throughout the community and which ones are culturally sensitive to different cultures. So that's an example of something that we are doing at the healthcare organization to make sure that we're reaching a variety of community members. So there's that. There's the advent of telehealth, and while it's great, it also has its limitations as well, because we're talking about marginalized communities that may not have the technology bandwidth to be able to utilize telehealth. So that's an ongoing challenge that we have in terms of reaching the community. But I'm not real sure if that is answering the question appropriately or if that's what you're looking for, but there are different ways that we are trying to reach out to community members and it's various platforms. And while we have a lot of technology at our hands, we also have a lot of challenges ahead of us to make sure that patients and community can, take advantage of those advances.
Yeah, that's awesome, Kevin. Thank you so much for that, right? And just really highlighting the fact that while technological advancements are great, right? It's not helpful for every community, right? So really having those important conversations with the communities that you're trying to serve with these advancements about what works best for them is really helpful, right? In moving the needle and making sure that whatever advancements organizations are making, that it's really hitting the mark, right? And that they're making sure that the communities that deserve these services can really access them. So thank you for lifting that up. Panelists, just want to say thank you so much for a wonderful and robust discussion. Your authenticity, your vulnerability, your openness, your passion. It's like so energizing, and I can truly feel it. So just thank you all so much for being part of this. So now I am going to pass it over to my colleague Chihira to wrap us up for today.
Thank you. So just like Abina mentioned, we recently published a brief highlighting the strategies that we shared in today's webinar, and I encourage you to take a look at this brief when you get a chance. In the upcoming months, we'll share an accompanying blog about the benefits of having an advisory committee to guide health equity work and some key strategies to keep in mind when developing this group. Next slide. For additional resources about health equity and other topics, please visit our website at chcs.org. On the website, you can download practical resources, learn about cutting-edge efforts from partnerships across the nation, subscribe to CHCS email updates to learn about new resources, webinars, and more. You can also follow us on Twitter at CHCS Health. Next slide. And again, we want to thank our panelists, you all for joining us, and Genentech for support. If you'd like to connect with the CHCS project team, our emails are on this slide. Please feel free to contact us at any time to continue these conversations. And lastly, please make sure to complete the survey from today's webinar. Thank you all so much and have a wonderful rest of your day. Bye, everyone.